Hello and welcome back to AtheroTalk, the podcast series hosted by the AAS Young Fellows. I'm Pelin Golforoush and I will be your host for today's episode. As part of our mission to make AtheroTalk truly global, we are privileged to speak with leading voices shaping the future of cardiovascular prevention. Today, we are honored to welcome Professor Raul Santos, a Brazilian cardiologist and lipid specialist at the University of Sao Paulo's Heart Institute and researcher at Einstein Hospital, Israelita, in Sao Paulo. A former president of the International Atherosclerosis Society, he is internationally known for his research on familial hypercholesterolemia, LDL-lowering therapies, triglyceride disorders, and lipoprotein little-a. He has helped shape national and international lipid guidelines and led FH registries and cohorts across Latin America. Professor Santos, it's a real privilege to welcome you to AtheroTalk. Thank you very much for joining us.
No, thank you, Pelin. It's my pleasure. Thank you very much for inviting me to be able to do this podcast. EAS, I've been a member of EAS for many years. We have lots of friends there, so I'm really honored to participate.
Before we dive into the science, we'd love to start on a more personal note and get to know the person behind the work. So let's start at the beginning of your journey. Could you start by introducing yourself to our listeners? Who is Raul Santos beyond the titles and achievements?
Okay, good. So I'm a Brazilian, first of all, right? I'm a physician for more than 40 years now. Actually, I'm a very eclectic person. I like talking to people. I like to listen. I like to teach. Uh, I'm very fond of traveling. I speak 4 languages. And this is something that I always like very much because to be able to communicate and to know the culture of different places. And I'm very fortunate because of that. Also, I have things that I like doing, like listening to music. I'm a very Beatlemaniac guy. I love the Fat Four. Uh, I like watching movies, and I'm a very good fan of sci-fi series. And also, I like the Muppets a lot. So, as I told you, I'm a very eclectic person.
That's really good to hear. And it gives us a great sense of your life in general, besides all the science. And every journey comes with its own set of challenges. What challenges did you face early in your career, especially working in Brazil or Latin America?
Oh, that's a good question. I graduated 40 years ago. I did my training in cardiology, and I wanted to work with science, right? And even if was in a very, let's say, developed center for my country, in the Heart Institute of the University of São Paulo, at that time in the 90s wasn't still is the number one cardiology institution in Latin America, but it was very complicated to find a place here. Even if I volunteered, just to tell you, I stayed 10 years as volunteer here until I was hired as an assistant physician. And I remember that at that time, doors were not open. So I really had to open my way. I had to find my path into science. So I went to the pharmacy school at the University of São Paulo, despite the fact that I was a cardiologist, attending physicians, and I did my master's degree and PhD degrees in food science. And actually, I knew a lot about coronary heart disease at the time, but actually this thing going away from the clinical thing a little bit and doing a little bit of something different opened tons of doors for me. And that's why I really got interested in this thing about atherosclerosis and this relation with this lipidemia. And I remember at that time we were, let's say, at the beginning of the statins and all the neurotherapies that were showing up. And that really changed my career, because it gave me a terrific opportunity. But those were hard times because I had to survive on, scholarships. I had to survive on working at weekends at the ER, stay on calls at hospitals, at holidays, Christmas, and everything. because even so in Brazil, it's a little bit complicated for the young person, especially not only the young physician, but the young healthcare professional that wants to get into science to really, let's say, have funding for really, improving his or her own career. I felt a bit anxious, and I worked very hard, and then things start to come. And I'm very happy. I can say I'm a happy person, and I achieved a lot of success from, especially coming from where I come from. And so and I think my journey. I always tell the younger people that I meet here, my students, my mentees, that you have to persevere. You have to put something in your mind, and you have to fight for your ideas. Of course, if you have nice people that can help you, it's easier. But you have to go after your dreams, and that's how I see it, and that's how I built my whole career.
That's a very important point, and I'm sure most of our listeners can relate to this. Thank you for sharing that experience so openly. And bringing it back to the present day, as a cardiologist specializing in lipids and atherosclerosis, what daily habits do you personally follow for cardiovascular disease prevention?
Oh, definitely. I follow the my what I preach. So I try to eat well. We have a nice diet. If you consume the classical, typical Brazilian diet like rice and beans, low fat meat, chicken, fruits, vegetables, etc. Some pasta. Okay, we have the big barbecue places in my country, but we don't attend to these places very frequently. Okay, so I try to eat well. I exercise. I never smoked in my life, and I take a pill to reduce my cholesterol, even if my LDL is not high. I consider that as inadequate, and I've been for more than 15 years taking statin. Then I moved to statin as my combination because I believe that if I start early, even if my LDL is not so high, I can, reduce the risk of cardiovascular disease. So basically, that's what I do: healthy lifestyle and treat my cholesterol.
That's great to hear, and actually very practical and relevant for both clinicians and the public. So let's shift now from your personal journey to your scientific work and the evolution of the field. You've had a remarkable career in lipidology. You worked extensively on familial hypercholesterolemia, triglyceride disorders, and lipoprotein little a. What drew you to lipid disorders early in your career, and how has the field evolved since you started?
I remember when started getting interested in lipids. I think I saw it as an opportunity because here in Brazil there were very few people interested in this lipidemia, and I remember we at INCOR we already had a clinic, a small lipid clinic, that was founded by people that came before me, and I saw that there was a huge opportunity to increase that, to make that thrive. And actually, I adopt familial hypercholesterolemia as the disease that I was really interested in because there was, so little things being done for that disease in the country. And I remember I started attending the ETS Congress in Europe in the end of the 90s. I started getting in touch with colleagues like John Castelline in the Netherlands, some colleagues in the United States that worked with MedPad. And then I started, attending these meetings, starting to do networking, starting meeting people. And actually, that's why I started growing on this. And so I saw that was a huge opportunity to really invest on the lipid field, especially FA in the country. And fortunately, we have achieved a nice, not a much bigger clinic. Now we have more clinics in the country. I have mentored a lot of people on this, and I'm very happy with what I have achieved in this field. I think it's very important because over the last 30 years, there was a huge revolution in the field because I remember I started with the statins. Actually, one of the first numbers, the New England Journal of Medicine that I read when I was finishing my residence training, actually showed the first study of simvastatin in people with familial hypercholesterolemia. And actually, over the 30 years, we had such growth in understanding the lipid metabolism. We had the discovery of PCSK9 inhibitors. We have this, lots of science on Pelin, the newer therapies, the newer ways of doing risk stratification. And now we're talking about sRNAs, ASOs, gene editing. Such an amazing progress that we had over the 30 years. And I'm very happy that I was able to participate and to contribute to this development.
Yeah, it's impressive to see how much the field has
Yeah.
progressed over time. You've been deeply involved in FH registries across Latin America. What have these registries revealed that we didn't fully appreciate before about FH in real world populations? Are we doing enough in early detection, especially for conditions like FH?
This is a very nice question, because actually over the last 30 years, actually, uh, the knowledge about FH, about the genetics, about the natural history, about risk of cardiovascular disease, and the therapies has evolved in such huge manner. And we know much more of the disease nowadays than when I started. And actually, I have participated not only in local Brazilian registries. We started the HyperCol Brazil cascade screening program, but I also was able to collaborate with the familial hypercholesterolemia Foundation when we created the Ibero-American Network of FH. Then I was able to work with EAS on the FHSC registry. And actually, we have learned a lot. So the disease is much more frequent than we thought. The risk of cardiovascular disease is much more heterogeneous than we thought. Uh, and so I think that really made us understand much more about it. And now I think are much more empowered to deal with FH. So, and I think this is extremely important because the registries really taught us a lot.
Yeah, that really highlights the importance of real-world data and early detection strategies. Building on that, what are the biggest barriers to implementing cascade screening programs globally?
You know, there's some lack of knowledge about how FH is frequent. Despite all the evidence that we have nowadays, it's 1 in 310 people. If you go to places where we have founder effects, it would be much more frequent. But I always used to say that FH is a family disease. It's a disease that runs in the family. So 1 in every 2 are affected in families with FH. That's why we need the cascade screening. And unfortunately, still we do we still find index cases, but we don't check the families. And there's still, lack of awareness on this, on the family transmission of the disease, lack of funding for doing the cascade screenings. For instance, here in Brazil, our cascade screening program is still sustained by special, let's say, grants from the government that are set for research, not necessarily for care of the patients. And it was not supposed to be so. Okay, research is important, but we have to have funding for patient care, and we still don't have it. And if you go to other places in Latin America, it's even worse, if you go to Argentina or Colombia or Mexico. So there's a lack of funding for doing the cascade screenings for identifying people. And it's so easy to find people with FA. You just have to measure cholesterol. Just to have to find people that had early coronary heart disease and check the families. And unfortunately, we still a huge barrier on that, the implementation of all the knowledge that we have about it. So I think this is still a big, despite all the advances that we had, in countries like my country, the knowledge about that phase is much higher now. We have guidelines, but we have the genetic testing, but still the implementation of the recommendations is still much worse than they was supposed to be.
Yeah. While most attention goes to FH registries, do you think establishing registries specifically for familial chylomicronemia syndrome patients would help advance research, diagnosis, and treatment? Is there such a registry in Brazil?
Definitely, FCS is not as frequent as FH. It's more or less like homozygous FH, right? Affecting between, 1 in 300,000 to 600,000 people. But we might have some founder effects actually in the country, especially in the Northeast. And actually, I think we're living now with FCS what we lived with FH 20 years ago, because we don't have so many registries in FCS. And actually, let's say we have an idea, but we are not totally sure about the natural history of FCS. We know it's a disease that is associated with a greater risk of pancreatitis, etc. But there's a lot of heterogeneity on the clinical manifestations of FCS. So definitely, we still need registries, robust registries, as similar to the ones that we have for FH, to better understand FCS. And answering the second question, yes, we have a registry here in Brazil that is chaired by Dr. Maria Cristina Izar from the Federal University of Sao Paulo. And actually, she's working with many colleagues to really try to find these patients and actually to have the adequate diagnosis in order to try to implement adequate therapies. We're going to discuss a little bit about the therapies later, because there's a lot of barriers in Latin America to these more advanced therapies, because they're a lot very expensive. And for us here, it's really complicated to treat more severe disease like FCS or OFH. But I think the registries are very important to really understand what's going on, not only in the country, but, as I said, to have an idea of how the disease really is.
Yeah. Taking a broader global perspective, how do disparities between high and low income countries affect cardiovascular prevention?
Oh, this is excellent. Now we have evidence from the registries, especially the FHSC, that unfortunately, people with FH in low middle income countries are diagnosed later, have more severe disease because they're not controlled adequately. They have a greater rates of atherosclerotic cardiovascular disease, and they are less well treated than high income countries. And definitely, these disparities that have been shown by these registries are extremely important in order to really try to change the environment in low middle income countries. So we let's say we can compare, let's say, what's going on in, let's say, more developed or more affluent societies, and this can help us to set some public policies in order to improve the care of our FH patients and other severe lipidemia patients in low middle income countries.
That puts things into a crucial global context. Thank you for addressing that. Staying with clinical practice, what's one misconception about lipid management or atherosclerosis prevention that you'd like to clear up for our audience?
Yeah, I think there's no such thing such as hypercholesterolemia. Actually, we all have inadequate LDL cholesterol levels, right? So in most people will have myocardial infarctions with LDLs of something like 120, 130 milligrams per deciliter. That is something like, let's say, 3 nanomoles per liter. And actually, to think that if your LDL is over, let's say 4 or 160, and you have hypercholesterolemia, is totally inadequate. 95% of the population has inadequate LDL cholesterol levels. And this is something that physicians and actually the legislators, the healthcare authorities don't understand very well. And definitely we work to have much lower LDL levels than we have. I have worked very hard with Prof. Ray on the World Heart Federation cholesterol roadmap. And we have to implement the policy of early intervention in the cholesterol, because even if you're not so intensive regarding the therapy, but if you start very early, reducing the usual cholesterol levels in the long term, you can make a lot of difference in prevention of cardiovascular events.
One topic that continues to generate discussion is LDL lowering. We often say lower is better for LDL. Do you think there's still skepticism in the medical community, or is the evidence
Oh,
now definitive?
I think we have enough evidence that very intensive LDL cholesterol lowering can make the difference. And not only the lower the better, the longer the better. So we should start earlier than we do because for patients who already have lots of atherosclerosis, they benefit from intensive therapies, but they still keep having lots of events, even with the best therapies available. No, so this is one thing, and the other thing is that a lot of physicians and a lot of healthcare practitioners and a lot of, let's say, lay people, they really don't believe in that. They say, oh, this thing about cholesterol comes from pharma, it comes from industry. And this is not correct, and that is we must work much more with education regarding the need for therapy. And definitely, if you're a very high risk person, definitely LDL should be lowered very intensively. But if you're not, you didn't get to that, let's say, stage yet, right? If you start earlier, you don't need to be so intensive regarding therapy because people will benefit from the long-term lower LDL cholesterol levels. And this, it's you start a statin, low dose statin, very early. You know that it's safe, it's not expensive, and can make a lot of difference. No?
Yeah. Even with strong evidence, implementation can be challenging. Do you think clinicians are still too conservative when it comes to LDL lowering? What do you see as the main drivers of therapeutic inertia in lipid management?
You know, most individuals have inadequate LDL cholesterol levels, and most patients still have high LDL. In part, it's because of us, because we put the goals very low, right? So we're talking about, let's say, less than 55 or 1.5 nanomoles per liter or lower values. It gets more complicated to give with the usual therapy. So you need PCSK9 inhibitors and blah, blah, blah. But I think, physicians are still very conservative about that. So they don't believe that if you treat people more intensively, you're going to get extra benefits. Because they're concerned about lack of benefits. They're concerned about possible adverse events of very low LDL cholesterol. And nowadays, we have very robust evidence that very low LDLs are really safe and to prolong life. So, and of course, I think one thing that, especially in low middle income countries, when we're talking about intensive LDL cholesterol lowering, one barrier is the access to the newer therapies. Because in Brazil, we have the PCSK9 inhibitors, but they're not reimbursed. We don't have them in the public system. And it gets very complicated to have access to these therapies. So this is another barrier related to the system that we have here. So lack of awareness, lack of knowledge, lack of will, and the lack of therapies. And also, barriers in monitoring patients, in following patients. So I think we have many issues that we have already studied. And we must work in really try to, let's say, to circumvent these barriers and to improve the care in low middle income countries.
You've also worked on Lp(a). With emerging therapies targeting Lp(a), do you think we are on the verge of a new era in cardiovascular prevention?
I've been working with Lp(a) for more than 30 years. Actually, one of the first studies that really pushed me to the lipid field was when we tested the possible impact of high Lpa on the thrombolysis after a myocardial infarction event. Because at that time, we didn't do much PCIs. We used to use TPA or streptokinase, etc. And there was that thing that Lp(a) could block fibrinolysis. And I remember one of the first studies that we did with Lpa was at many in 1992, something like that. And definitely we have very robust evidence, not only from the epidemiological studies, but from genetic studies, the gain of function or loss of function varies related to Lp(a). The Lp(a) is independently associated with the risk. We don't have yet the evidence that reducing Lp(a) will prevent cardiovascular events, but we are in the verge of that. We're in the brink of that because now we have at least 5 or 6 very robust therapies And hopefully the first study that will be read this year is going to be Horizon. And hopefully there's going to be a positive trial. One thing that is important to tell the listeners is that we're not expecting miracles, right? We're expecting that these therapies will reduce the risk of events by 15 to 20% on top of usual care, because we're talking about 5 years duration of studies, etc. But in my opinion, if these trials are positive, we're gonna have to think how to deal with lipids again. We're gonna have to rethink that, because we're gonna have to treat LDL very intensively, but we also will need to treat high LPA. And this, of course, will be very nice, but at the same time, will bring another challenge, right? Because we're going to have to use two therapies. Sometimes we're going to have to use, let's say, more advanced therapies like PCSK9 inhibitors for LDL, and we're going to need to use these advanced therapies for Lp(a). And that brings, again, the issue of cost effectiveness, access to therapy. So I think it's going to be an interesting trouble to be solved after these trials are positive, and hopefully they will be positive,
Yeah, it's a very exciting time. It's definitely an area to watch closely. Now, shifting from research to the bedside, can you share a memorable patient interaction that changed how you approach dyslipidemia management?
I think many years ago, we had the opportunity to participate in a clinical trial was called TALSIG, when we were testing the effects of evolocumab, a PCSK9 inhibitor, in patients with familial hypercholesterolemia. And I remember for that study, actually, I chose my worst patients. They had very severe high LDLs, many recurrences of cardiovascular events. And I've been treating these patients for almost 10 years now with the PCSK9 inhibitor. And it's amazing how well the drug worked, and how low the LDL went, and how well the patients are doing. Because I remember these patients, they kept having events one after the other, because their LDLs were still very high despite the use of statins. And when we gave them the therapy, and now we followed them for so many years, and they're doing so well, this is something that really was impressive. And the other thing that I like to say is, nowadays we're working with ApoC3 inhibitors for people with familial chylomicronemia or severe hypertriglyceridemia. And the experience that we had with the small interfering RNA for, it was clozadiran, I think, for ApoC3, and also idea for ApoC3. When we saw the results, when patients got into the open phase, it was amazing, because they used to have triglycerides something like, 20 nanomoles per liter, and now they have something like, 1 nanomole, half nanomole. So this is amazing, because these patients were desperate for having therapies, and now they were able to treat them. So this is fantastic.
Yeah, those are fantastic stories. Thank you for sharing those. Looking at the bigger picture, what do you see as the biggest unmet needs in atherosclerosis research today?
Atherosclerosis is a very heterogeneous, multifactorial disease, right? And of course, lipids have a very important role on that, but it's not only the lipids, right? It's inflammation, it's insulin resistant, and it's thrombosis. So I think still, despite all the benefits that we were able to bring to the patients, I think we have many challenges on that. In my opinion, I think one thing that needs to be advanced more in the field is to really, let's say, have more precise methods to identify people who are going to get benefits from a specific therapy. So I'm not talking about precision medicine. So we have patients that might benefit more from, let's say, intensive LDL lowering. Some might got more benefit from, let's say, antithrombotic therapies or anti-inflammatory therapy. So I think this is still a challenge, because it's impossible to give antithrombotic, GLP-1 agonists, very intensive LDL cholesterol lowering, anti-inflammatory therapies all at the same time for the same person. So I think this is a big challenge in the field that we have nowadays, and we're gonna have to, let's say, have more instruments, let's say, to direct the more adequate therapies for each person. That's how I see it.
That really helps frame where future efforts should be directed. Given your
There-
international Given your international experience, what lessons can Europe learn from Latin America and vice versa?
You know what? I think the Europeans can learn from us. We should not take things from for granted. We need to, because in Europe, because it's much more developed. So you in Europe, you have, let's say, things that are more set, that run more smoothly, and sometimes you might get accommodated with the stuff that you have. Here in low middle income countries, especially in Latin America, when you want to do something, definitely you have to fight a lot. You have to work very hard. You have to contact. You have, I think it's extremely important, and I think this is something that Europeans can learn from us. But the other hand, I think one thing that Europe has that is very nice, and I learn a lot from my colleagues in Europe, is that you have to build networks. You have to, to work together in order to each one of us, let's say, give a little bit, and then you can achieve much. And so I think this possibility of cooperation that we have in Europe is very nice. And this is something that definitely we're trying to do here, try to build here. And this is something that actually in my career, I think I achieved a lot of success because I was really able to interact with a lot of people. And I published papers with people from all over the world, from Europe, from Africa, Australia. You take a place, China, Iran, whatever, United States, Canada. And so this thing about interaction and networking and one helping the other, uh, I think, is extremely important. And this is something that I learned from my colleagues from Europe.
That's a great perspective on collaboration across regions. Looking ahead over the next 10 years, what will change cardiovascular prevention the most? Earlier detection, new therapies, or better implementation of what we already know?
Yeah, that's a quite challenging question because actually I think we have issues in all of these items, right? As I said before, early detection of people at risk can make a lot of difference because we can implement pharmacological therapy in addition to a healthy lifestyle very early. And this can make a lot of difference in the long term. Newer therapies definitely are very important because we still have challenges in controlling the risk factors. I think for LDL, I think we're done with LDL. Of course, people are going to try to invent different therapies, but with what we have nowadays, and in my opinion, one thing that is coming that's going to be very interesting is the oral PCSK9 inhibitor, especially if the costs of these therapies are low, because then you'll be able to really give uh, this medication for a lot more people. And maybe here in low middle income countries, the accessibility to these therapies might become much higher than we have nowadays for the monoclonals or the siRNA drugs. And one thing that is extremely important, we always discuss nowadays, is implementation, right? We have lots of evidence, but we don't follow. So I think we have to work very hard in implementation science, and it's a quite big challenge. Uh, I guess this is not only for us. Maybe for us it's even worse because of, let's say, the characteristics of our health systems. But implementation is the word. Definitely, we have to work. We need to have multi-professional teams. We have to find different ways of identifying people, following people in the long term, checking whether they're taking their medications. So I think this is really, really important because otherwise we won't be able to fully achieve what we can do for the patients.
Although your work is strongly rooted in clinical practice, if you had to prioritize one or two areas of basic cardiovascular research that could truly transform clinical practice in the future, where would you place your bets?
Oh, that's also very challenging. Uh, Thinking about the let's say the prevalence of excess body weight, obesity, I think this is a scourge. not only for developed regions, but also developing countries in the world. So definitely we must finding ways of let's say, developing adequate, very well tolerated and accessible therapies for prevention and also for treating obesity very early. I think this is very important. And also one thing that I see with very good eyes is early identification and implementing therapies for people with, let's say, genetic diseases like FH. And I think these gene editing therapies that are being developed, I think they could be game changers, you know? So I think if we're really able to change what's causing the disease, or at least change some genes that will really attenuate the disease, I think this is going to make a lot of difference in the future. So I do hope that actually we will be able to develop these newer therapies for the near future. You know?
Before we wrap up, we'd like to move into a more reflective part of our conversation. We always include a section we call the graveyard of ideas. Science is full of brilliant ideas that didn't work out the way we expected, but often taught us something important. Could you share a research idea, project, or therapeutic approach that initially failed but ultimately helped advance the field?
You know what? One of the big challenges of the lipidologist and actually of the usual clinician is to deal with people with fixed epidemic of hypertriglyceridemia. And we put a lot of money in fibrates, you know, because fibrates reduce triglycerides. We have some evidence that fibrates could reduce the risk of cardiovascular events. But in the end, the fibrate trials were negative. So I was able to be at the steering committee of Prominent that tested fibrate, and we tried to reduce the risk of cardiovascular disease in people with diabetes, right? And it was a total failure. And Cecilia, I don't think fibrates can do a lot good nowadays for cardiovascular disease, but we learned that these drugs might be important for reducing the burden of microvascular disease. So we have evidence that they can reduce peripheral artery disease. We have evidence that they can protect the kidney. We have evidence that can protect the eye. So I think this is something that actually of course, we targeted the heart, the brain, but we found interesting for the microvessels. So I think this is an example of how one thing that didn't work, but worked on the other side. So I think the fibrates are a good example of that, you know.
That's such a valuable reflection. There's a lot to learn from those experiences. This has been a truly inspiring and insightful discussion. Thank you, Professor Santos, for sharing your time and insights with us.
No, I really, as I said in the beginning of this podcast, so thank you very much for giving me the opportunity. You know, I'm very thankful to the EAS because I've been to work with EAS for many years, and they gave me lots of opportunities to try to develop. So I made lots of friends, and being able to really share a little bit of my career and my experience and my science. So it's really very rewarding, and I'm very happy that you invited me to participate in this podcast. Thank you so much.
Thank you so much again. And to our listeners, thank you for being part of the AtheroTalk community. This podcast is for you, and we truly value your feedback. Please don't forget to share your thoughts or suggest topics you'd like us to cover in the future episodes. And stay tuned.